right, so here what we're going to do is that we're going to talk about the large size vasculitis, and mainly we're going to talk about the Takayasu arteritis and also the giant cell arteritis, right? And just quick review, the medium size vasculitis disease includes Kawasaki disease, polyarteritis nodosa, and Behçet disease, are also called thromboangiitis obliterans. And we talk about the small blood vessels, which are oncopositive, and the immune complex. And most importantly, for the oncopositive, you need to remember Wegener disease, or also called granulomatosis with the polyangiitis, or Churg-Strauss, which is also called what? Allergic granulomatosis with polyangiitis, and also the microscopic polyangiitis. And then small blood vessels vasculitis also includes Henoch-Schönlein purpura. All right, that's a review. But now here we're going to talk about the two important large size vasculitis, and one is called, let's just write down here, it's called, what is this called? Giant. All right, we call them a giant cell, all right, arteritis. And what is the other name for these guys again? All right, we already talked about it. It's called Wharton disease, right? Also called, everybody knows, it's also called temporal arteritis, right? And what is the other name again here? Which is called cranial arteritis, right? Now, so one of the thing you have to remember for giant cell arteritis is really what happens is that obviously there is there is inflammation to the large blood vessels, but really what happens is that usually these are mononuclear cells, a CD4 T lymphocytes mediated inflammation that actually goes into these blood vessels, right? And that basically results into inflammatory reactions. And it's because of that, that T cells started producing like a lot of the cytokines, correct? And that results into what? Very, very important. This is something that you remember. Look, let's write down here. It's a T cell, right? T cell are like a CD4 mediated, all right? Mediated inflammations is going on, right? And because of this T cells sort of mediated, that result into what? Narrowing, let's just say narrowing of the lumen. Because whenever there's mononuclear cells are present there, what happens? They infiltrate, right? And they can obstruct the lumen, right? That's what they can do, one of the things. So there's a narrowing. And on top of that, this area, whenever there is a narrowing of the lumen, and the way that happens is that, they form something called, this is a granuloma, all right? So it is a granuloma formations, or, this is a granulomatosis vasculitis, right? And this is very, very important that you need to remember this. And other thing that you should also remember here is that, this disease, like giant cell arteritis, it is, it's heavily associated, let's just say, it's associated with something called polymyalgia, all right, myalgia rheumatica. And you need to remember this, right? It's very, very important. Most of the time, this disease, giant cell arteritis, is associated with polymyalgia rheumatica. And if you remember that, usually people with polymyalgia, they come with what? Like stiffness, right? Stiffness, aching, right? Aching pain on their what? On their neck, right? The neck, or lower back, or even their shoulder, right? Or even on their limbs, right? So you have to remember that, these people with it's a polymyalgia, because poly is many muscles, right? There's a rheumatosis is going on there. So because of the, patient will come with stiffness, aching, pain on neck, lower back, and shoulder. These are the classical symptoms that people come with, right? So remember, the giant cell arteritis or Wharton, it is an inflammatory, it's a T cell mediated, right, inflammation that basically causes a narrowing of the lumen and result into basically, in histopathological, use basically this mononuclear cells, right? Mononuclear cells like T cells, B cells, plasma cells, they infiltrate, right? Infiltrate and basically, and basically form something called granuloma, right? That's what they do in this case. Now, in this case, what really happens is that, there's a lot of like cytokines are produced, right? Because there's inflammation is there, there is a basically severe, the cytokines are produced. And those cytokines, like for example, IL-1, the IL-6, tumor necrosing factor, right, is because of this, IL-1. What happens is that they can go to the hypothalamus, and what happens is that, cause basically fever, right? Usually you can see a fever. That's one of the classical symptoms you can get. Obviously there is a, myalgia is there, why, right? And obviously there's a Arteritis is also there because of the cytokines is produced in there. And these guys actually go to the most important organ, like for example here, this IL-6 especially predominantly, and even the IL-1, and so they go and they basically release something called acute phase reactants, right? And when they go to these acute phase reactants, what really happens is this, they can start producing something called, let's just say C-reactive proteins. And you do see elevated level of C-reactive proteins, and they also produce like fibrinogen, right? These are some of those acute phase reactants. And this fibrinogen, you know what they do? Fibrinogen can go, and if you remember, what happens is that, fibrinogens have this like red blood cells, right? And red blood cells have what? Phospholipids, right? And phospholipids that have their negative charge. It's because of the negative repulse negative, so that's why they don't aggregate. But whenever this fibrinogen gets released, right? What happens is that these fibrinogen can go and like basically coat these red blood cells, and as they coat these red blood cells, what happens is that they lost this negative charges, right? They lost this negative charges, and it's because of this, when they lost this negative charge, because of the fibrinogen, they started aggregating with one another, right? So if you take, let's just say, pipette tube, if you take a blood person who has this high level of this, right, and if you put, let's just say, in the tube, this pipette tube, right, and then if you actually put a sample into it, right, and really what happens is that you get to see there is the red blood cells rapidly going and sedimenting in the bottom, and they're actually forming something called Rolex formations. That's what you see, right? So it stacks of the red blood cells that you see, right? So the rapidly red blood cells will go and sit on the bottom of the tube, right, aggregating one another because there's a loss of negative charges because of this fibrinogen, right? And this phenomenon, whenever there is a something called rate is what delta length over the delta time, right? The time it takes for these red blood cells to sediment at the bottom of the tube, is what is called ESR, right? And it's because there is this fibrinogen coating, and then they have lost the negative charge. Whenever you put on this pipette tube, really what happens is like red blood cells basically rapidly go and stack with one another, right? And that is basically what leading to there's a rapid or fast or ESR. So this is what is called erythrocyte sedimentation rate, all right? In your exam question, sometimes they ask you this, right? What can actually increase your erythrocyte sedimentation rate? And one of them is a fibrinogen, right? Very, very important that you should remember that. And other one is maybe, let's just say, immunoglobulins can also play a role. So fibrinogen, immunoglobulin, basically, they increase the erythrocyte sedimentation rate, right? And that is something that you have to remember. And because in this case, giant cell arteritis, you have a elevated or high level of erythrocyte sedimentation rate. You also see high level of C-reactive protein. Sometimes this can even cross like more than 100 millimeters per hour. That's pretty high, all right, when it comes to erythrocyte sedimentation rate. So you must remember this. Why there is a elevated erythrocyte sedimentation rate? You must remember this because sometimes they ask you, right? So now, just think about this. These are these are classical symptoms. These are, you get the classical symptom, this systematic symptoms, right? And we also talked about the elevated of level ESR and C-reactive proteins. But think about, the giant cell arteritis. This inflammation mainly involves, right, large blood vessels. But to be very, very specific, it involves the blood vessel that has to do with the external carotid arteries. So if you remember, look at this. This is heart, right? So this is a blood vessel. This is aorta, right? Aorta, this is a pulmonary trunk. Aorta coming here, and aorta give branch like this, right? What is this branch? This is called brachiocephalic trunk or innominate artery, which can split into two part. It can give you this subclavian artery, and also give you another branch called, what is this other branch that going? This can give you like a right common carotid artery, right? And the right common carotid arteries can further break down so later into what? Right external carotid artery and right internal carotid artery. So I can simply say this is a right external carotid artery, and then you can simply say this is a right internal carotid artery. It also gives one more branch from like right down here, right? And that is what does this got? This is basically called left common carotid artery. And left common artery can also split into our two branch. We can simply say this is what? Left internal carotid artery, and we can simply say this is left external carotid artery, this one, right? And also gives one branch here from the subclavian artery, right? This is left subclavian artery, so branch like this. So these are three branches, right? Your brachiocephalic trunk, left common carotid artery, and left subclavian artery, right? left common carotid artery, right? Just the common carotid, they go and split up into what? Left internal carotid artery and then left external carotid artery, right? This external carotid artery, these branches are very, very important because it gives you like a lot of those branches called superior thyroid artery, right? One of the branches called lingual artery, and the most important that we're talking about is a temporal artery. Okay, it gives you branch. We'll just say, well, we'll make one branch and we'll say it go give branch something called, this is, let's just say for our case, it's a temporal artery. It gives a branch as a temporal artery. It's very, very important. And this temporal artery is supplying where? It's supplying basically, your basically temporal area, and then also the muscles of mastifications that bring oxygen in blood to that tissues. So remember this, that whenever this guys, right, this inflammatory process, they attack the external carotid artery, right, and its branches like temporal arteries, really what happens is that you can get inflammations of that blood vessels. That is why the name comes like temporal arteritis. The reason why we call them a giant cell arteritis is because whenever there's a granuloma formations happens, right, the inflammatory cells are there, that let's just say the macrophages are there, right? Macrophages are there, and the macrophage, what happens? A lot of the debris are there, and on top of that you have a lot of these giant cells, basically, this macrophages level of interferon gamma, right? Remember like how the T helper cells, right? The CD4 positive cells, right? They release what? Especially CD4 positive, which is the T helper 1 cells, they produce interferon gamma, right? Those interferon gamma basically converts what? The macrophages into epithelial cells, like they have looks like epithelial cells, and then later level of the interferon gamma also converts the epithelial cells into giant cells, right? And then whenever you have a giant cells, all this, forming this granuloma, right? Whenever there's a T cells, there's a macrophages are there, the epithelial cells, and then giant cells are there. And in the periphery right down here, there are those plasma cells and all this are also making this, right? And this whole thing is what is called granuloma, right? And that is why we call them, this is a giant cell, basically, giant cell arteritis, right? So now you know why we got this name, all right? Now, just think about it, that if there is involvement of this inflammatory process that is basically narrowing the lumen of these arteries, right? This temporal arteritis or this blood vessel, then just think about what can happen to, or what are the classical symptoms that you can get. Like, let's just say if it's involved temporal, right? One of the most simple things that really happens is this. Let's write down here, right? The blood vessel that is actually supplying to those tissues, where is that going? That is going to your muscles of mastifications, right? Like especially like temporal muscles and so. So when you have that, there's obstruction lumen, then there's less blood is going there. You remember our favorite equation, what is this? Flow is equal to what? Your flow is basically equal to delta pressure, we can simply say this, and we can simply say let's just say resistance, right? Resistance, so resistance determined by your radius, right? So if there's obstruction and narrowing of the lumen is there, resistance goes up, the flow decreases, right? And when the flow decreases, really what happens? As you chew, because as you chew, your muscles are moving, right? You need more nutrients and oxygen to the tissue. And your blood vessel and your blood, because of obstructions, what happens is that, they cannot basically dilate and they cannot receive more oxygen. And that results into what? Claudication, right? That is called claudications. So one of the most classical symptoms you get is something called jaw claudications, right? This is one of the most important things you get on these people, right? Second thing you should get is that, so because there is a blood vessels, like you remember, not only this, if it's external carotid arteries, or depends on where the this involvement is there, the inflammatory process there. Sometimes really what happens is that there is a obstruction to basically this the ophthalmic artery, because usually remember this guy's involved. Like I'll quickly write down here, temporal artery. All right, this is important. This temporal artery, or let's ophthalmic artery, or let's just say even vertebral arteries, right? So, and highly associated with that. So these are the main branches that involve, right? So remember, there's a jaw claudication is there, right? And you feel, and because of this, look, you also feel pain, lots of pain, right? And let's start to think about this. Lots of pain, jaw claudication is there. And let's just say blood vessel that is actually going to your brain, right? If that is compromised, then what happens? Or think about this blood vessel from the left, the internal carotid artery, right? That goes and breaks down into further branches and gives one of the blood vessels to ophthalmic artery, and ophthalmic branch that breaks down and gives you what? Retinal artery, right? So you basically have what? If there's basically this inflammatory process happening on those blood vessels, all the classical symptoms you can get is like diplopia, right? Diplopia, or like those sort of like a ocular disturbance. That's what you get, right? That's one of the things you can get, or sometimes that can also result into what? Blindness. Total blindness can even happen. Blindness. So And usually, look, remember, it depends on where, but remember this, like, even this blood vessel, it divides internal carotid artery and supplying to this, so this is supplying the right eye, right? And this can supply the left eye. So it depends on where the inflammatory process is. So you can get basically mononuclear, let's just say mononuclear, like a vision disturbance, something that you have to remember, right? Vision disturbance, one side of the eye, that can be disturbed, right? And if it's actually the perfusion that is actually going to your brain is also disturbed, then what happens is the brain started what? Dilating, right? And what happens when you start dilating, they started hitting those dura mater, and when you start hitting the dura mater, what happens? That causes a headache, right? So look, these are some of the classical symptoms. You have a patient with this giant arteritis, they come with a jaw claudication, there's a pain, there's a diplopia, right? And you sometimes the mononuclear one-sided visions, sometimes that can even lead into what? Total blindness, that happens, right? But one thing that you have to most remember is that, these conditions, this is rarely you see people who are less than 50 years old, okay? You rarely. So you must remember this. You must remember this. Like, this typically happens people who are greater than 50 years old. And you must remember this. This is like the most important things you have to remember this, right? Because this can help you to get the answer correct. So the temporal arteritis is most commonly seen in elderly people, especially most commonly seen in female, but who are age greater than 50 years old. So onset of headaches, fever, jaw claudications, diplopia, right? Or even mononuclear visions, right? Increased level of ESR, they have a fever, right? And all those like myalgia, arthralgia, you can get with this conditions, with the giant cell arteritis, right? And you need to remember all this like classical symptoms that you have to get, right? Onset of symptoms usually happens after the 50 years old, right? Like headache, fever, pain, diplopia, jaw claudication, that very important, right? You should remember this. Not only like, you can have a it's not nuclear, it's ocular visual loss, but it can even have let's just say, depends on where the inflammatory process is taking place, but it can even result into, let's say, biocular visual loss too, right? And, usually, like, the patient, when they come to like a severe pain, like facial pain, like, basically pain on chewing, pain and chewing is very important, right? Pain and chewing, important that, right? So, remember this, in your exam questions usually, right? They usually say the patients are 50 years old, right? With the jaw claudication pain, or maybe associate maybe they might give you a symptom that has the polymyalgia rheumatica, right? Diplopia, occlusions, and then you have basically elevated level of erythrocyte sedimentation rate or C-reactive proteins. And histological feature they might show you. And the history, what do you have? You basically have the granulomatic formation is there, right? And and why they're attacking, especially the internal elastic lamina. So you see the basically internal elastic lamina that been fragmented, right? So there's a granulomatous lesion where basically this internal elastic lamina, right? Internal elastic lamina has been fragmented, right? So your take-home message is, remember this, people who are 50 years and greater, and that is also one of the risk factors, like age, or if you have a prior, before getting this temporal arteritis, if you have a prior history of basically, transient visual loss, that could be one of the biggest risk factor, right? That is something that you have to remember. And, the way you treat this patient is by giving the high level of corticosteroids, right? Treatments involves like high level of corticosteroids and high level of corticosteroids, and especially to prevent the blindness, very important, all right? To prevent corticosteroids. All right, this is something that you have to remember. Now, all right, guys, we're going to quickly discuss about what we've discussed so far. Okay, please remember, these people often when they come with they are like a female that's greater than 50 years old, right? Comes to the clinic with fever, like fatigue, weight loss. Right? These are classical symptoms that you see. Unilateral headache, jaw claudications. We already discussed about all this stuff, and also monocular vision loss, right? But what I do want you to remember is this one. This is a very important point, and this point is this, that irreversible, this blindness, all right? It is a very important point they make, the visual loss, right? And the reason why that happens is because of why? Because there is a optic, this point, optic ischemic, like anterior ischemic optic neuropathy is there, because of that, there's a reduced blood flow is there, right? And that can lead into what? This one, irreversible blindness. It's a very important point. And remember, you could have a visual loss. It's because of these conditions, or it could be because of there's a central branch of retinal artery occlusions, or it could be because of this one, right? So any any of this could lead into blindness. All right, and it's a very, very important that you remember this classical symptoms. All right. And remember, this example that I'm showing you, that basically shows you what? There's a temporal arteritis, right? Now, another point that you have to remember is that this condition is often associated with this condition called polymyalgia rheumatica, right? And oftentimes, like whenever in the clinical veneer, when they give you, sometimes they associate, with these conditions. And usually this patient will have muscle pain, stiffness, especially around this area. What is this called? Shoulder, right? Or even in the neck area right here. And remember, the worse in the morning, meaning that any sort of like a physical activity they do in the morning, that get worse, right? Remember, the pain can also, stiffness can also see in the pelvic girdle. But I do want you to remember this point, though. The creatinine kinase is a normal in these patients, all right? It's a very, very important. Now, another point that I would like to make is that if you look at this histological findings, right? Look at it. This is basically lumen that you see, right? There's a lumen. But look at it. This condition, what? It is basically granulomatosis condition, right? Where there's basically, you see infiltration right here. Look at this. All these infiltrations, right? And you have to remember this point because it is high yield. Oftentimes, they can maybe show you a histological image and then ask you this. And this is basically large cells vasculitis, right? Where basically, usually the temporal arteritis is what? Large cell vasculitis, where there's a lot of infiltrations you get to see, right? Now, if you look at this here right here, another image, if you look at this one right here, right? These are basically the image of like giant cells, right? What are giant cells? Basically, they are modified epithelioid cells, right? And this is a classical one you see, like you see 1 year 2, right? So sometimes this condition can also lead into necrotizing giant cell granulomatosis condition, right? It is very, very important that you know how to look at this in histological. Oftentimes they ask you, boards loves temporal arteritis, so you must remember this, all right? Now, other things I want you to remember is about the treatment about the giant cell arteritis, right? The treatment for this is like, especially if you want to like control, like prevent blindness or death, you need to give this treatment, which is, what is this called? This is called glucocorticoid, right? And oftentimes they can give you drugs like prednisones or methylprednisolone, right? So this is very, very important, right? You must remember what is the treatment, how you treat for the temporal arteritis or giant cell arteritis, please. Thank you.